Good evening, everybody. Um, Thank you for the invitation and the generous introduction. And I have to say, it is a huge honor to follow such eminent researchers as Dr. Hall and our colleagues from Glasgow. So the title that you've given me is Outcomes of Bariatric Surgery in Patients with Type 2 Diabetes Mellitus. And let me see if I can do justice to the topic. We were asked by the ASO to have this disclaimer. So Novo Nordisk has provided sponsorship to the ASO to fully fund this webinar, and they've had no influence on the content. They certainly haven't had any influence on the content of my presentation, and I have certainly not received any fee for participation from them. So in order to structure the talk this evening, I know I've got 15 minutes or so, so I'm going to break it down into a few parts. So we'll go through what are the current recommendations. Then to the uninitiated, we'll talk about which bariatric surgical procedures are relevant. Then we'll discuss, does bariatric surgery actually do any good to patients with type 2 diabetes? We'll talk about the risks and the other benefits of surgery. Then we'll talk about the current scenario in patients with diabetes. Then we'll discuss into more minutiae this topic and some concluding remarks I'll want to leave you with, I hope. So what are the current recommendations? So in 2014, NICE, the National Institute for Healthcare and Clinical Excellence in the UK, came out with the CG 189 guidance, which was an update on previous guidance. And in that, for the first time, they suggested that patients with type 2 diabetes who have a body mass index of 35 or more should be offered an expedited assessment for bariatric surgery. And for the cohort with a BMI of 30 to 34.9, they said consider an assessment. So they took the word expedited out. That was quite landmark in terms of the guidance by NICE for healthcare professionals in the UK, because we know how religiously we tend to follow them, and whether or not they've been followed, we'll discuss that in a moment. Following that, and Rubino et al. Did some path-breaking work with DSS consensus guidelines in 2016, and obviously they were endorsed by some 50, 60 national societies as well. I think they went a step backward from NICE, but still huge progress in terms of world scenario, where they came out with strong recommendations that metabolic surgery should be a recommended option to treat patients with type 2 diabetes with class 3 obesity, body mass index of 40 or more, regardless of the level of glycemic control or complexity, as well as those with lesser degree of obesity, BMI 35 to 39.9, with inadequately controlled hyperglycemia. So again, they were slightly low in terms of, compared to the NICE guidance, I think slightly lower in terms of the strength of their recommendation, but still hugely supportive of diabetes or metabolic surgery in patients who are suffering from type 2 diabetes. So from there, I will just take you very quickly to which procedures are relevant, because I recognize that I'm talking amongst a group of non-surgeons, and not everybody might be familiar with what we do as bariatric surgeons. So largely, in the world of bariatric surgery, we are now talking about 2 and maybe 3 procedures. So we talk about sleeve gastrectomy, we talk about Roux-en-Y gastric bypass, and we talk about one anastomosis gastric bypass. And why do I say that? I say that because this is the last IFSO survey that we have. This was published in 2018. It was conducted in 2016, but still gives you some sense of the direction of travel. So the purple bar there is the gastric band, and you can see, I think largely on the back of what our colleagues are doing in the USA, because they do half of the bariatric procedures in the world. The numbers have plummeted right down to 3% in 2016, and I would like to think less than 2% now. Sleeve gastrectomy has been the dominant story of the last decade, and it's just showing continued rise and rise and rise. Roux-en-Y gastric bypass is beginning to fall as well, and the surprising new kid on the block is the one anastomosis gastric bypass, which my estimation is that somewhere we are at around 10% mark in the world today. But because the American Society ASMBS does not endorse it, it cannot rise any higher than that, because I think sometimes less scientific and more other reasons, but this is not what we want to discuss today. So with that, I can nicely move on to, does surgery actually help? So let's just see what evidence there is. I could not start this section without paying respect to Walter Porres, who first wrote this in 1995. Who would have thought it? An operation proves to be the most effective therapy for adult onset diabetes mellitus. I think we are building on the works of laurels such as him, and we've now got a huge amount of evidence to support what he then said. To put things into context, I'd like to just take you back a step. We bariatric surgeons, and I know some people have challenged it and some also disagree, we tend to define complete remission and partial remission because, let's face it, we were the first group of clinicians who actually were dealing with remission. So we made up our own guidance, and the HbA1c of less than 6% is largely regarded as bariatric as complete remission bariatric literature, and HbA1c of 6 to 6.4% is regarded as partial remission. I know there are different views out there, but that's what our literature does concentrate upon. So this study, published in the NEJM by Shower and colleagues, a world-recognized group, world-recognized study, and what they found, I'll have to stop my own picture. So they found that in the intensive medical therapy group, 5% patients achieved the primary endpoint of less than 6%, less than equal to 6% at 5 years, as opposed to 29% in the group with Roux-en-Y gastric bypass and intensive medical therapy, and 23% in the sleeve gastrectomy and intensive medical therapy. And even with these small numbers, significant differences. This was at 5 years. Another study, this study is a comparison of two procedures, the sleeve gastrectomy and the Roux-en-Y gastric bypass. But if you don't focus on the comparison at the moment, for the moment, just look at what's being achieved. So complete remission of diabetes at 1 year in 75% of patients in the Roux-en-Y gastric bypass group and 48% in the sleeve gastrectomy group. Again, there are differences amongst the procedures as well, but that's not what we're talking about here. For the purpose of this talk, there was significant improvement in diabetes in both arms. Let's move on to another study. This study I bring in because, as I said earlier, the one anastomosis gastric bypass is not approved in the USA. So I think that has actually prevented us from understanding this procedure more. But this was a randomized controlled trial comparing the Roux-en-Y gastric bypass and one anastomosis gastric bypass, published in the Lancet. And this trial was powered to evaluate excess body mass index loss at 2 years. So it was not powered to evaluate differences in diabetes outcomes. However, the definitions were largely the same. But what we found, these differences were not significant, but still you can see, clinically they might be. The complete remission was 60% in OAGB as opposed to 38% in the Roux-en-Y gastric bypass, and the partial remission was proportionately lower. Overall, the numbers were not much different, but to me, that seems like that metabolically, OAGB is slightly superior to Roux-en-Y gastric bypass. Again, these differences were, in this study, not statistically significant because of the numbers, because the study was not powered to evaluate those differences. And I hope future studies do look at this. And there are other studies, and if you want these papers, I can send them to you. There are many studies showing that bariatric procedures are superior to just general medical management or dietetic-led management in terms of diabetes outcomes. Having said that, we know that not everybody continues to have very good outcomes in the long term. But again, in comparison, we have seen with the intensive medical treatment also, largely the literature is 1 or 2 years outcomes, and we don't really have any long-term outcomes. With bariatric surgery, we do. And this is a paper we wrote with our colleagues in Cleveland, led by a world-famous researcher and my friend Ali Aminian. And we found that 32% of patients who experience late relapse, and it does happen in approximately a third of the patients as well, even in those patients, there was a significant improvement in other health parameters. And the conclusion was that even in those patients where diabetes does come back, those patients also have significant benefits from this surgery. So largely, if you ask me, what have we learned from this literature and the studies that I have not presented, is that patients who have a body mass index of more than 30 to 35, and if they have type 2 diabetes, then I think they do better than not having surgery. And if you look at the data from the Public Health England, a large number of our patients who are suffering from type 2 diabetes actually fall in the overweight or obesity category. So this is just one picture I took from the PHE's website, but that's a known fact, to be honest. And this group is I'm sure, more aware of this than anybody else. But there are risks, and as a clinician, if I have to balance the talk, we have to talk about that as well. So surgery has 30-day mortality, and there's a price being paid by some individuals for the benefit of many. So what is that? So within the 30-day, we know that from the UK data that we have a 30-day mortality of less than 1,000 overall for all bariatric procedures. And we know from some very strong American data involving thousands and thousands of patients that sleeve gastrectomy has a 1 in 1,000 30-day mortality, whereas Roux-en-Y gastric bypass has a 1 in 500 30-day mortality. And then there are complications as well. So some of these complications can be life-altering, and we're talking between 5 to 10% 30-day complications, approximately 2 to 3% severe complications. Complications also happen after 30 days because it's not just 30 days. So in the long term, patients can develop ulcers or internal hernia or nutritional issues. And once again, we see higher complications with Roux-en-Y gastric bypass compared to sleeve. And generally, we're talking 5 to 10% long-term complication rates as well. So there's a price to be paid for surgery, and there is no surgery that is without any risk. But surgery has other benefits. We were talking about weight loss earlier with different dietetic interventions, and we know that when we talk about surgery, and of course, weight loss and diabetes outcomes are interrelated, but surgery delivers significant durable weight loss, which can improve so many other health conditions that we can't talk about today because we haven't got the time. It improves the mental health of the patients, improves quality of life, reduces overall risk of cancers, improves cardiovascular risk, and reduces mortality and reduces healthcare costs. So surgery, when we talk about for patients with type 2 diabetes, we also have to factor in that it also has multiple other benefits that we need to think about. And how does it compare against the current outcomes? So this is again going back to NICE, because NICE does set clinical standards in this country. And NICE says we should aim to support patients with diabetes to have an SpA1c of 6.5%. But if they're taking a drug which could cause hypoglycemia, maybe aim for 7%. That's what NICE says in CG20, NICE NG28. But how are we doing? This is Diabetes UK data, so I'm inclined to believe it. 6% of patients with type 2 diabetes have exceptionally high blood glucose levels, putting them at serious risk of complications. 2 in 5 people with type 2 diabetes are meeting the recommended treatment targets. So I think there's room for improvement. This is National Diabetes Audit 2017-2018 data. Lo and behold, same trend still. And here, the targets have been changed to 7.5%, not what NICE said in NG28, which was 6.5. Even then, how are we doing? 65.8% patients with type 2 diabetes are meeting that target. A third are not. And this is, I think, a more relaxed target anyway. But I think this is probably the elephant in the room. We know that the burden of disease in communities across the world is so much that we cannot realistically think of operating or offering operations to all our patients. It is beside the point that this option is not being considered by many clinicians at all for any of their patients, but that's not the real problem. I think the real problem has so far been that we have not understood which group has the maximum benefit from surgery. I think we know that surgery benefits overall, but unless we start to identify the maximum benefit cohort, I think we will not start to change the scenario in terms of the performance of surgery in this country and around the world. So do we know anything about it? We do. I think there's some data coming out which can predict which patients do better in terms of diabetes. So this particular study, it is I think, symbolic of what we've seen. That's why I've chosen this one. Patients with complete remission were significantly younger, had shorter duration of diabetes, were not on insulin therapy, took fewer oral hypoglycemics, had higher C-peptide levels, lower preoperative HbA1c, and they were less likely to have had hypertension or dyslipidemia, and more likely to have had a higher weight loss, which is all common sense. And I think we've seen this from many studies, but this will need to then influence the clinical decision making, and we need to develop clinical side models where we can apply this surgery with a sort of, with the aim of finding out the group where patients have the lowest risk versus benefit ratio, or the highest benefit ratio. So this is one group that we need to understand, because we do not know that. The second thing we do not know is that which group of patients with lower burden of obesity, and I'm talking about body mass index of 30 to 35, recognizing fully that body mass index is not the only way to assess obesity, but this is the one which is clinically used. And we need to identify which cohort in that group would benefit most in the long term, so that we can aim to then target those individuals. For example, we do not know, we heard about the effects of insulin, and Dr. Hall's talk was an eye-opener for me, I have to say. But we don't know if, when patients are being managed on oral hypoglycemics, and we're thinking of switching them to insulin, should we offer them surgery instead? Because there are cohorts within the diabetes population where the benefits could be more than the others. And I think we need to start looking at that more seriously in the future. So I would like to leave you with some concluding remarks. In my opinion and experience, bariatric surgery is grossly underused, and more so in the UK, but around the world. I think we do not have the resources to operate all patients with type 2 diabetes with a body mass index of more than 30. So we need to identify patients who will benefit most. Now, this is partly political, partly the reality of the world I live in. Patients with obesity and type 2 diabetes should be offered a real evidence-based choice regarding their treatment, and they should not have to jump through hoops in order to qualify for surgery. The final decision should be theirs, not ours. And to be honest, if there's an evidence-based treatment out there, it should not be left to surgeons to push for surgery. It should be everyone's job to push for it. So with those concluding remarks and thoughts, I'll leave it here. I think I've said enough, and we'll look forward to the discussions with colleagues and the panelists.